Get started. Again, welcome everyone to this Region 7 Disaster Health Response Ecosystem webinar titled Tiny Victories, Pediatric Burn Response in Disasters. Introduce our presenters here real quick. So we have with us today Dr. Julia Slater. She is a plastic surgeon and the medical director of the Burnett Burn Center at the University of Kansas Health System. Dr. Slater cares for patients with acute and chronic burns, acute and chronic wounds, and burn and non-burn scars. Dr. Slater is trained in general surgery, burn surgery, and plastic surgery before taking her first job at the University of Cincinnati. She worked as the medical director of UCMC Burn Unit and as a burn surgeon at Shriners Hospital for Children in Cincinnati. We also have with us today Judy Placek. Judy holds a master's degree in nursing and a postmaster's certificate as a family nurse practitioner, both from Clarkson College. She has been a dedicated employee at Nebraska Med since 1996, specializing in burn and plastic surgery. Her role with roles including providing comprehensive intraoperative inpatient and outpatient care for patients undergoing acute and reconstructive burn and plastic surgery. This February, she earned her certified burn registered nurse certification, underscoring her expertise in the field. She served as the Midwest Region Burn Disaster Coordinator for 7 years and has worked closely with the American Burn Association, as a consultant and continues to contribute to this field as a member of the ABA Disaster Committee. In October of 2019, she joined us here with the Region 7 Disaster Health Response Ecosystem, where she currently serves as the Burn Specialty Team Lead. Judy's commitment to global health is evident in her participation in numerous burn and reconstructive plastic surgery medical missions across China, Haiti, India, Bangladesh, and Africa. Her expertise has been recognized through presentations on burn care and disaster preparedness at local, national, and international levels. And with that, I will turn it over to our presenters.
Thank you so much, Tom. Can you hear me okay? Perfect. So it's an honor to be here. I really appreciate the invitation. And Tom already hit my introduction, so I won't introduce myself again. If you go ahead and hit the next slide. As he mentioned, I have no disclosures. I will make a disclaimer just in case you didn't catch it with the topic being burn. There will be clinical pictures of burns. I thought it was the easiest way to really help describe what we're looking at with burns and help you get a better idea when we're talking, especially about figuring out depth and staging of the burns. So I know a lot of people are probably eating right now if you're in Central Time. Or in our Western times. So just a disclaimer that there are some graphic clinical pictures. Next slide, please. So just the objectives, I know Tom was talking about them quickly. I'm really going to handle talking about what are the characteristics that we currently see in treatment of pediatric burns, what does it look like to assess and to give early treatment to pediatric burns? And then Judy is going to do a great job afterwards of really tying it all in into what does this look like in a disaster scenario, especially when we're talking about having a lot of pediatric burns in that disaster setting, and what are the unique challenges that we're going to face in something like that. Next slide, please. So just getting us started at the understanding pediatric burns. Next slide. You know, you got to know what we're dealing with before we even get into the specifics of it. So how common are pediatric burns? This slide, it's getting a little outdated now because the last data collection on this was from 10 years ago in 2014. But this is a slide depicting visits in the emergency department for burn injuries in pediatric patients or anyone under the age of 18 across the United States. And you can see that there's a trend down over the time from 1990 to 2014, but that it kind of has plateaued a little bit there. And that's what we've been seeing in the last several years as well. Next slide, please. So again, that slide just represents kids that are presenting to emergency departments. It doesn't incorporate anybody who just went to their pediatrician or family medicine doctor or had a smaller injury that they just treated at home. But that's still about 100,000 kids being seen annually in our emergency departments, even without any disaster issues happening. And that's one child every 6 minutes. So in the course of this hour that we'll be here, there's 10 kids that are going to present to the emergency units across the country with a burn injury. And while we have seen that decreasing over the last 30 years, it's still a significant number. And we see that that kind of mirrors adults as we have gotten as a society more focused on safety. Smoke detectors are much more prevalent. We have safer cars and things like that. We are seeing a lot less injuries, which is great for the burn population in general. Next slide. So we know how common it is, but what we need to know is, how serious is it? And so this is data that's brought to us by the CDC, and burns are actually the 9th most common cause of death in our pediatric patients. And when you break it down by even smaller age groups, we see that in just a few years ago, 2017, which I guess is more than a few at this point, but it was actually the 3rd most common cause of death for children ages 1 through 4. So it's not insignificant. And we're seeing that when our pediatric patients get burned, it still can be very serious for them, with about 340 deaths per year, the majority being unintentional, some unfortunately being intentional injury and death. Next slide, please. And then, what is the impact of that to our health system? And what we see is that if about 100,000 patients a year are presenting to the emergency rooms with pediatric burn injuries, about 7% of those are going to require admission. And that 7% itself makes up more than $1 billion in costs for our total annually for their total inpatient care that they need during those stays. So it's not an insignificant number. And beyond just the money of this, we know that, pediatric burn patients are going to have lifelong physical and mental health impacts that are going to impact both them and the health system in general. Next slide. And then, so now we know how common it is. What mechanisms of injury are we going to see? And what we know is that kids really have very different, most common mechanisms of injury for burn injuries than our adults. And it changes by their age. But the majority of our toddlers, things like that, are going to be a lot of contact burns from reaching up and touching something hot, like that little one that's about to touch that hot pan on the stove, or a lot of scald from pulling down. So they see the coffee cup on the counter or the ramen noodles on the counter, and they think they can help get themselves their own lunch. And so they pull it down and they get these scald injuries on their skin. And so a lot of those are going to be just a hot liquid that goes on and comes off really quick, or maybe a contact burn where you have a deeper burn, but it's a pretty small area because it's where it was contacted. Certainly, chemical burns are something that are common in our children, especially if they're kind of getting into cabinets and they find cleaning products or things like that within the house that they might accidentally ingest. I don't know the age of the group here, but these Mr. Yuck stickers were very popular when I was growing up. And I don't see them as much anymore, but we certainly had them all over all of our things. But it's really important, when thinking about having kids around chemicals, that we're making sure they understand the risks and not getting into those. As our kids get older, we see more contact burns from helping with cooking, and then we start to see more true thermal or fire injuries that we think of, like house fires or playing with matches, things like that. Now, I think it's pretty notable that we've seen a lot less of the matches, the lighters, as the population in general has decreased their smoking habits, which is helpful, that these matches and lighters are just not as readily available, and that helps decrease that. When we think of a burn disaster and we look at the last several burn disasters over the past decade, I think it's really interesting to note that most of them are nothing like these common mechanisms for our pediatric patients. So it's apartment fires, like the apartment building that caught fire in England. It's volcanic eruptions, wildfires. It's the ignition of the colored powders in the water park in Taiwan that happened several years ago. And so when we think about a disaster scenario with pediatric burns, I think we need to recognize that not only are we going to be treating a lot more pediatric patients, but we're going to be dealing with a lot of injuries which are not the most common presenting injuries for these patients. So a lot of our patients that do get admitted scald or contact, it's very rare for them to have an inhalation injury component with it, or to have significant problems with airway and things like that, which would be much more common in a lot of these scenarios that could have mass casualty in a burn injury. And so we need to think about that as we're preparing for it, both in how to take care of the patients and what supplies that we need for that. Next slide, please. So that's kind of the basics of what we see for burns. Now I really want to spend a good amount of time talking about what is the initial care for pediatric burns and highlighting some of the special things in a pediatric burn that would be different from an adult burn patient. Next slide, please. So when I talk about burn patients and initially presenting to groups, I like to remind people that, we need to treat them as a trauma patient. And oftentimes the burn injury does have a traumatic mechanism to it. And outside of a few things in burn, like a very severe inhalation injury, or maybe a severe carbon monoxide inhalation or cyanide exposure, there's not much of an actual burn injury that is going to be a rapid threat to life as much as a traumatic injury. So when a patient rolls in with a bad burn injury, especially if it's a small child, it's very scary looking. But it's much more important that we make sure we're not missing a significant traumatic injury underneath that we aren't seeing because we get distracted by the burn. And so it's important to put these children through normal ATLS protocol. And so I've got our ABCDEs on here. I've got our little reminder of the Breslow tape, great for helping whenever we have a pediatric patient, help us with what are the dosages of medications that we need? What size equipment should we pull out? So it's going to be commonly used for all of our pediatric trauma, but especially our pediatric burn patients. And we're going to go through our ABCDEs just like we would for an adult. And actually, the first place that really burn injury itself, especially the cutaneous manifestations of that, come in is when we get down to that E, to that exposure. We're starting to get all the clothing off of our patients so that we can get ready for our head to toe exam in our secondary survey. And this is kind of the first place that you're going to be interacting with the burn injury for the patient. So if it's a chemical that the child spilled on themselves, you're going to be getting that clothing away that might be soaked in that chemical and might still be exposing the skin and getting more burning. We talked about how the little toddlers like to pull down hot fluids. Well, if they're wearing a diaper, as that hot liquid comes down them, it's going to get soaked up by that diaper. And diapers are amazing at wicking up liquid if you aren't potty trained, but not a great thing to have on if you're getting hot liquid down you that's going to hold that hot liquid in contact with really soft and thin skin of the genital area. So getting them exposed, getting that diaper off to stop that burning process is really important as we're going through that primary survey. Next slide, please. And just as we are in that primary survey, we're still on A with our airway. It's really important to think about the fact that a pediatric airway is not the same thing as an adult airway. Kids have these really big, really floppy tongues that tend to be taking up a lot of space in their mouth, can make it hard to get a view. The epiglottis is a lot floppier. There's a different narrow point of the airway. So the narrowest part of a child's airway is going to be your cricoid, not your glottis, like in an adult. And in general, the airways are just a lot smaller than our adult airways. And so if you already have a small airway and then you're adding an inhalation injury, edema to the tissue that starts to swell, you're going to have a lot more occlusion of that airway a lot quicker than you would necessarily in an adult airway. And so that's something to keep in mind as far as timing to getting them intubated before that edema really is taking over and making it more difficult for you to be able to get your airway in place. Next slide, please. On that, we want to think about our endotracheal tube selection, if that's what we're putting in. A lot of times historically, it was thought that you want to only put in an uncuffed tube in pediatric patients because you don't want to have issues with necrosis or things like that from the balloon. But we actually really recommend in these pediatric burn patients where there's going to be changes with the edema to the airway, where there's going to be a lot of manipulation because they're probably going to need a lot of surgeries and things like that, that you place a cuffed endotracheal tube in these patients. Just wanted to put up there the reminder that kind of the formula that we use if we're trying to figure out what size tube, you can do 16 plus the child's age in years and then divide that sum by 4 to get the size. Or you can estimate it based off of either the size of the child's nares or the pinky finger, which, coincidence that the pinky finger is exactly the same size as the nostril, so they can slide that little finger up there all the time. But those are 2 other ways that you can just look at the child and get an estimation of the size of endotracheal tube that you want to place for your advanced airway. Next slide, please. We get to our circulation, you're getting IVs started. You want to get your IV fluid started with that. So this is coming directly from the American Burn Association. This is something that we teach when we're teaching our advanced burn life support class or our ABLS class. So when you have a pediatric burn patient and you are just eyeballing them, remember, you haven't stripped them down at this point. You haven't done a head to toe exam. So we haven't calculated what their true total body surface area or TBSA is for their injury, but you are just looking at them and you can see that it is more than 20% of their body or more than 1/5 of their body. You're going to want to get some initial fluid started. And this is just to get it going before you've calculated what their needs are actually going to be. And so what we recommend is that if you have a child 5 or less, you start them at 125 milliliters of LR per hour. If the child is between 6 and 12, you go up to 250 milliliters per hour. And then if you have a 13-year-old or older, you do what we would do for the adults and do 500 milliliters of LR per hour. And again, I just want to emphasize that this is your initial fluid rate. This is before you've calculated the true extent of their injury. And this is going to change once we do get to that secondary survey. Next slide, please. So we've gotten through our ABCDEs. Now we're getting ready to really do that head to toe evaluation, our secondary survey. Information that can be very helpful to get. We use the amplet mnemonic for this: allergies, medications, past medical history, last PO intake, the events leading up to it, and tetanus and their childhood immunizations. With your pediatric patients, it's more likely that you're going to be relying on family members to get you these answers if the child is not old enough to understand, or the child is too upset from the injury. They're not going to be able to answer these for you. Next slide. Yep. So now we are actually taking a look at it, and we are actually going to be able to figure out how deep are their burns. And so this is just a little cartoon of the skin. Some things I want you to note is just, you've got the different layers of skin, the epidermis, the dermis, and then you've got that subcutaneous fat that's kind of protecting the vessels, the muscles, and all the deeper structures. We have our hair follicles and our sweat glands that live way deep in that dermis. And that's where where you can really get skin healing from. And so as the depth of the burn gets deeper and it starts affecting those structures, you're going to lose the ability for skin healing within the wound and then need to rely on skin healing from the edges of the wound. And so that's what kind of starts to influence whether we think a wound is going to heal in a timely manner or if we're eventually going to need to intervene with surgery. So we'll just go through each of these depths. Next slide. So superficial first degree, I'm sure a depth that most of us have had. I will fess up, I have had more than one first degree burn. This is going to be your sunburn, but it is erythematous. It's very red. It blanches if you touch it. It's very painful. It's dry. There's not blistering. There's not fluid loss. And so it hurts a lot, but it's going to heal very quickly. And because it's just in that epidermis, you're not having fluid losses through it. And so we tend not to see the systemic responses that we see with the deeper burns. And so these are not burns that are going to need resuscitation. So one thing I didn't mention that I should have mentioned in that initial fluid slide is that when we are saying a patient is 20% or more total body surface area, that means burns that are second degree or more, not first degree burns. So we're never calculating them in our TBSA because of the fact that they don't impact systemically like those deeper ones and that you don't have fluid losses through the surface of them like the deeper burns. So these are not going to be calculated in our injury assessment for the patients. Next slide. In the medical world, we break down second degree burns into two different types. So we have a superficial partial thickness burn or a deep partial thickness burn. And this just is kind of dependent on how deep in that dermis is the burn. And as I mentioned before, you've got those structures down in the dermis. And so in a superficial partial thickness burn, you're in the upper parts of the dermis and those are all preserved. And so you're going to get good healing. And so these are burns that we don't worry as much about needing to have to do surgery. They blister when you take that blister off. They are pink. They blanch when you touch them. They are painful. They are wet. And so those are the ones that we, treat with wound care and monitoring, but often don't have to surgically intervene on them. Next slide. As opposed to our deep partial thickness where you can see a lot of these areas a lot more pale in the middle there. If it blanches at all, it will blanch very sluggishly. The patients are going to start to say, hey, I don't really feel you touching. Like maybe I feel the pressure, but I don't feel pain. They're not as painful. They do still have blistering. They are still wet. But this is where you're really getting towards the bottom of that dermis. And we're going to then have interruption of the ability of the wound to heal very well within the wound itself. And you're going to be relying on the wound edges. And so those burns tend to take much longer to heal and often need surgical intervention in order to get them to heal. Next slide. And then our full thickness or our third degree burn is going to be burns that are going to go all the way through the skin. They're often very leathery, very dry. You don't really have the blistering most times. You might have like the whole sheet peel off with it, but if it peels off there, everything is very pale. Nothing blanches. They actually don't usually hurt because of the involvement of the nerve ends and the damage to them. And so they're not nearly as painful as our second degree or especially our superficial partial thickness. And these are the injuries that are going to need surgical intervention once they get to a burn unit for treatment. Next slide. And I think it's really important that we talk here about some skin, especially anatomy differences that come up that are important for these injuries. So when you're dealing with a baby or a very small child, maybe a toddler, it's important to note that the skin is much thinner. So you can see in this cartoon that not only is the outer layer of epidermis, that stratum corneum, thinner, but also just in general, the epidermis is thinner. They also, in smaller children, tend to have a lot lot less subcutaneous fat. And so there's less protection underneath the skin over more important structures underneath. And so when you have less thickness here, if a child is going to touch something or be in contact with something, the same thing as an adult for the same amount of time, it's more likely that that child is going to have a deeper burn because of the thinner skin and the thinner subcutaneous tissue. Now, in pediatrics, as opposed to in like our geriatric population, one thing we do see is blood supply is much better. And so there is more potential for healing in our pediatric population than in our adult population. And also, less comorbidities that have affected blood vessels and things like that. So that's also important to note. Other anatomical differences, especially in our small babies, they have a lot less muscle mass. So shivering is not as effective for them when they start to get cold, and that can lead to increased risks of hypothermia. Next slide. Once we have seen what the depths are of the burns and we see that there is second and third degree burns on the patient, then we're going to want to calculate what is their total body surface area that's involved with their injury or their TBSA. So the most rudimentary but also least accurate way is going to be to use the Palmer method. And so the important things with this is to note that the measurement for the 1% of TBSA is going to be the entire palm as well as the palmar sides of the fingers. But even more importantly, this is 1% of the total body surface area using the patient's hand, not your own hand. And in pediatrics, this is really important because my hand is a lot different size than a 2-year-old's hand. And so if I'm trying to calculate TBSA on that 2-year-old with my hand, I'm not going to get the accurate answer. You need to use the patient's hand in order to figure out what the TBSA is. Again, this is the least accurate, but it's a very quick, fast, if that's what you have. Next slide. The next one, which is more accurate and also still pretty easy to remember, is going to be the rule of nines. So in this, we break body parts down by 9%. And so you've got 9% for a head in an adult. You've got 9% for each arm in an adult, 18 for the front of the trunk, 18 for the back, and then 18 for each leg. When we are dealing with children, we know that the proportion of their body surface area on their heads to the rest of their body is very different than in an adult. It's evolution to, one, make them appear cuter. So we want to take care of them when they are first come into the world and can't take care of themselves, but also there so that they can have rapid brain growth, as we have one of the largest brains for our body size. And so given that, we changed this rule of nines a little bit for our pediatric population. So in our pediatric population, the entire head is going to be 18%. Each arm is still going to be 9% like an adult. The front of the trunk is still 18 like an adult. The back of the trunk is still 18 like an adult. But we take the extra away from the legs because we know the legs are proportionally less of the total body surface area than an adult's. And so each leg is going to be 14. So it's a little different to remember because it's not a 9, but that's where we get the additional numbers for our head. Other things to remember for this, this is just breaking the body into smaller percentages to make it easier to figure out how much is burned. You still say what the part of it that is that's burned. So if I have a child with their face burned, but the back of their head is not burned, that's only 9%. I don't give them the whole 18 just because there's a burn on the head. If I have a child that just the lower half of the arm is burned, that's going to be 4.5%, not 9%. So you will definitely want to break it still down into what the actual area of burn is. You just want to use these numbers to help make it a little bit easier to remember. Next slide. The most accurate is the London Browder chart, and this is a chart that's often used in our burn units themselves. And that's because it's not something you can readily remember. You actually have to have it in front of you. And so, especially at the scene or in a disaster situation, this is probably going to be used later on, and not necessarily in triage where you may be using more of like the rule of nines to get through patients quicker. But the nice thing about this that I want to point out is you can see it kind of has this table here where it changes the numbers for the head, the thigh, and the leg, just like our rule of nines, but there is more changes based on the age. So in the rule of nines, the downside is that, you know, a baby's head is a lot bigger proportionally wise than a 10-year-old's head, but we only have the one option to go with the 18%. Here, it breaks it down to whether the child is an infant, whether they're 1, 5, 10, 15, or whether it's an adult. And so we'll use that for helping to calculate the total body surface area on these patients. Next slide. So as we're finishing with our secondary survey, we've been able to get a good assessment of the burns, how deep they are, how much of the burns are second and third degree, and what the patient's total body surface area is. Now we're going to want to adjust our fluid rates. And so now it comes to actually doing math. And so in our younger pediatric, so our less than 13-year-olds, we're going to want to do 3 mLs of LR times their weight in kilograms times their percent burn. And if you divide that by 16, it's going to give you your hourly rate to start your fluids at. If they're greater than or equal to 13 years old, or they appear to be about that age, then you're going to do 2 mLs instead of the 3. The other big thing to note here is that it's important to remember that the livers in pediatric patients don't have the same glycogen stores that they do in adults. And so when the body is stressed, there is not as much glycogen to convert to use as glucose in the body. And so these patients are more prone to becoming hypoglycemic, especially the very young patients. And so in order to prevent hypoglycemia in this acute occurrence, you want to really get some maintenance fluids with dextrose going. And so we recommend doing D5-LR, and you're going to calculate that at your normal maintenance rate using your 4-2-1 rule, like you normally would for a maintenance rate. And then as we put the fluids going, we typically will follow patients hourly to see what is their urine output and things like that, and adjust fluids up or down. You're not going to adjust that maintenance rate of the D5. You're just going to adjust your straight up LR. So we would keep that on throughout the initial resuscitation. Next slide, please. And so I mentioned, we're going to follow urine output in a simple, regular pediatric burn patient that's just, one patient that you're transporting or you're seeing in an ER that doesn't have a burn center. You're probably not going to have the patient with you that long on fluids that you're going to be monitoring them. But in a disaster scenario where it's a lot slower to move patients around, you may be titrating fluids. And so it's important to remember that we need to be looking at things like urinary output every hour to see if the patient's getting enough fluid. When we're talking about adult burn patients, the goal that we're looking at is 0.5 cc per kilogram per hour. Because younger pediatric kidneys cannot concentrate urine the same way that an adult can, we use a goal of 1 cc per kilogram per hour as our goal rate for our urinary output. So that's really what we want to be able to see in order to know that we're hydrating these patients well enough. Next slide. And then burn wound management. So oftentimes we have these blisters, and if the patient is a single patient, again, that's getting ready to be transported to a burn center, that's something that the burn center is going to be able to just take care of with debridement and getting them cleaned up. But if it is a disaster situation and patients are triaging that they're not as severe an injury, it's much more likely that a team may be taking care of a burn patient patient that doesn't triage higher to a burn center that wouldn't normally. And so it's really important in burn patients, pediatric and adult, that we're taking off blisters, one, so that we can see what the under part of the wound bed looks like to find out, is it a superficial partial thickness or is it a deep partial thickness that might need to go for surgery? But then two, so that when you're putting dressings on with antibiotic ointment or anything, or any of the silver dressings, that it actually is in contact with the wound bed so that it can help keep it clean and deliver the therapy to the wound bed itself. Also, you can have, especially in these hands like this, these blisters can get really large and they can impact the ability to move the digits, which can make it the fingers or toes or whatever get stiff, and which we don't want. So you want to debride them for that. Next slide. And then dressings. So again, in a scenario where you're just seeing a patient, you know they need to go directly to a burn center, and you want to just get them out the door, the first recommendation we give is to just use a clean, dry sheet. You want something that's going to help prevent the burn wound from sticking to a bunch of different things around it, as well as keep it clean and also not be wet to get cold and cause hypothermia. If you are treating a patient for longer, or it's a patient that wouldn't need to go to a burn center, we have a lot of wound dressings available to us. The important things that you remember is we try to do something that's non-stick. We try to have an antimicrobial proponent to it. And then we do layered dressing so that there is something absorbative, whether it be gauze, or an abdominal pad. Then we do compressive with rolled gauze and ACE wraps in order to help with edema control. In our pediatric population, the silver products that have come out, especially like the spongy ones that last a lot longer, so 5 to 7 days, have really made it a lot easier to care for these patients. Because if you have a superficial partial thickness burn, you can put that the silver dressing on it, and then by the time you're taking it off a week later, it's really healed underneath, and you didn't have to put the child through a lot of different dressing changes. Next slide. And then you want to make sure, especially as you're getting them ready for transport, or if you're caring for them for longer in a disaster, that you're watching out for hypothermia. We mentioned shivering is not as effective in kids. We mentioned that large total body surface area of their head. They can lose a lot of temperature or heat through that area. And so it's really important that these patients are staying warm, because when the skin gets violated with a burn injury, that skin can no longer help with temperature regulation, which thermoregulation is a really important function of the skin. And so we have to do that for them by providing warming blankets, possibly warming fluids, things like that for the patients. Next slide. Also really important for kids is going to be pain control. The same burn injury that we might be able to just debride at bedside for an adult, oftentimes we're not going to be able to for a child. And so we utilize a lot of sedation for our wound care for these patients, a lot of distraction for these patients. So if you have child life, or you just have TV or music, we actually do some virtual reality for the pediatric population to try to distract them. But you have to make sure that you're addressing their pain, and because if you don't address the pain early on, especially in a burn injury, they start to get a lot of anxiety, which it all starts to snowball and gets a lot worse with their pain control. So really important to consider for our pediatric patients and our adult patients, but special needs in our kids for sure. Next slide. And then just, the ABA, or American Burn Association, puts out the transfer criteria. I think everyone's aware of these. We had them for a very long time and they had not changed. They did change in 2023. And so I just always highlight that as of 2023, the American Burn Association has put for pediatrics, which in this they're defining as 14 or younger, that all pediatric burns may benefit from a burn center referral, given a lot of the things that we just talked about, as well as the possibility of things like non-accidental trauma or caregiver needs and things like that. Next slide. So that's kind of the basics of burn care initially, the basics of burns. I'm going to pass it over to Judy to talk about what about in a disaster scenario.
Can you hear me?
Yes.
Perfect. Dr. Slater, thank you so much for that great presentation. I am going to be talking about the pediatric considerations during a burn mass casualty incident and steps we can take to reduce mortality and save lives. Next slide. So the primary survey doesn't change and remains the priority during a pediatric assessment, just as it does with our adult patients, with a few special considerations. The distinct differences of the airway anatomy in the pediatric population, as Dr. Slater explained, and then jumping down to circulation is hemorrhage control. Burn patients, pediatric or adult, they don't bleed as a result of their injury like other trauma patients. So if there's a bleeding issue, there's an associated traumatic injury that needs to be recognized and treated. Burn patients are typically awake and alert immediately following their injury. So if their neurologic status is altered, other etiologies need to be considered. And then preventing hypothermia, Dr. Slater just talked about that. Preventing hypothermia in burn patients should always remain a priority, but it could be a challenge at the scene of a disaster when transport to facilities could be prolonged. Next slide. So children are more likely to sustain greater damage from smoke inhalation or from something like an aerosolized biological or chemical agent. Due to their physiology, they're at higher risk of absorbing dangerous amounts of chemicals or radiation through their skin. And children are closer to the ground, where contaminants may be a little more concentrated. They're at substantial risk, again, for hypothermia, which can happen from us decontaminating them outdoors when it's cold, exposure in the field or disaster site, or even at a healthcare facility that is not providing adequate heat source for them. And then children are more likely to develop shock due to their smaller blood volume and smaller fluid reserves. And then compared to adults, our children are more likely to have serious injuries with blood loss from blast injuries as the force of the blast is distributed over their small body. They're also much more likely to suffer from head trauma from blasts or other blunt injury mechanisms due to their unique body proportions, which again, Dr. Slater had alluded to. Next slide. So disaster plans should include planning for a minimum of 25% of victims from any mass casualty incident to be children. Calculation of total body surface area involved is critical not only in determining fluid management needs as well as whether transfer to a burn facility is warranted. And then as with the administration of any pain medication, you always want to start with the smallest dose of pain medication. But with a burn patient, it's really important to recognize that some burn patients may never be pain-free. And then as Dr. Slater alluded to, in our pediatric patients, you always want to monitor their glucose levels. Pediatric burn patients have higher metabolic rates than normal. They have higher glucose requirements. And then our critically ill patients can experience stress-induced hyperglycemia and insulin resistance. These down the line can be associated with skin graft failure and infections that really can threaten their lives. And then obviously pediatric patients have different emotional responses. They have different needs for understanding and healing from their traumatic events compared to our adult patients. Next slide. So just to review some definitions when discussing burn mass casualty incidents. So a BMCI is defined as any catastrophic event in which the number of patients exceeds the capability of local or regional burn centers to provide optimal care. So in order to provide optimal care, you need to determine what both your capability and your capacity are, which will differ from center to center. And within those centers, it could differ from week to week. Capability is the big picture. Capability is your staff, your supplies, operating rooms, equipment, et cetera, compared to capacity, which looks at how many beds do you have available to provide that optimal care to these patients. And so how many patients you can absorb really depends on the burn center's capability to provide that care and to provide that care over several days as the event unfolds. So for perspective, there are 132 burn centers in the United States. And there's less than 2,000 dedicated adult and pediatric burn beds total within those centers. Our burn centers typically function at about 90% capacity on a daily basis, which really doesn't leave that much room or take that big of an incident to overwhelm the system. Next slide. So when we look at the basic elements of disaster preparedness, surge capacity depends on 4 variables, with the more recent addition of systems. Next slide. So looking at space first, burns average, conservatively, 1 day of hospitalization per percent total body surface area burn, which really differentiates burn injuries from other traumatic injuries in that they often require a lengthy course of inpatient treatment. Because burn care, particularly pediatric burn care, is a really limited resource. It requires specialized care. All disaster plans should include procedures to identify available pediatric beds throughout the region so that children are placed appropriately in these limited beds. And so one of the most efficient ways to accomplish that is through utilizing a Pediatric Medical Operations Coordinating Center, or a PMOC. So what PMOCs do is they monitor and balance regional capacity and integrate with not only emergency management, but also with EMS and our coalitions. And so they function as a pretty much a regional hub for patient transfers and act as a single point of contact for hospitals, but not just during surge events. So what is really great about them is that they do this on a daily basis. And so this really increases their efficiency because they're familiar with the process. They're also a resource for matching patients to the right facility, which is really important because it allows for equity of access, especially for our community hospitals. Next slide. So it's really a multidisciplinary effort planning for and responding to a pediatric burn mass casualty incident. So when we start with our emergency management personnel, even including our mental health colleagues as well, any triage by untrained personnel can cause delays in treatment. This can result in increased morbidity and mortality. So some things we can do to try to mitigate that or modify some of our triage and treatment protocols when people come in contact with unusual injury mechanisms, which burn can certainly fall in one of those. Next slide. So the successful, really long-term outcome of these patients is dependent on our additional team members who are also specialists in caring for these patients. They include our child life colleagues, teachers, our child psychologists and psychiatrists, as well as our reconstructive burn surgeons who are skilled in identifying when the appropriate time is to perform reconstructive procedures on these children during their development. Next slide. So I think to start overall when talking about telehealth support, it's important to think about, like, what is the ask? What are you asking for when requesting pediatric subject matter expert telehealth or resource support? Also, it's important to recognize that the successful utilization of telehealth is dependent on the capability existing between both the referring and the receiving facilities. That is really important in making telehealth work efficiently. The Region 7 team is doing a lot of work in this arena, including leading a Region 7 information sharing work group to identify solutions for patient tracking, as well as bed capacity dashboards. This includes getting leaders together from national specialty organizations to develop best practice guidelines for regional MOCs, not only for pediatrics, but also for trauma, infectious disease, RAD, and burn. And also work is underway in the development of a regional pediatric medical operations coordinating center housed at Children's Mercy in Kansas City, which is this image shown here. It is quite an impressive facility that they have there in Kansas City. Next slide. So ASPR launched the Western Regional Alliance for Pediatric Emergency Management, or RAPM, and Region 5 for Kids in 2019, as well as added Gulf 7 in 2022. And what these pediatric disaster centers of excellence bring together are children's hospitals and national organizations. And they're designed to really kind of disseminate best practices in pediatric, not only preparedness, but response and recovery on a regional level. And so they have really been great partners of ours, contributing their expertise to the pediatric section of our region burn plan. So many thanks to them for their contribution to our plan. Next slide. So in addition to space and staff considerations, we also need to consider supplies for the burn patients. So ensuring that our facilities are equipped with age and size appropriate equipment, like our Foley catheters, our ET tubes. Routine wound care dressings may not be available. So everyday items like cling wrap or saran wrap, socks and t-shirts, those things can be used to prevent hypothermia. They can be used to keep topical ointments or dressings in place. And so it really kind of forces us to think outside the box with our wound care. But it is something to consider, especially when there's a large scale incident. Perhaps many of you have heard of the DASH tool, which can be found at dashtool.org. This tool was developed by Asper. It is designed as a preparedness tool, not a response tool, which is really important when using this tool. There are 4 modules, including the burn module that you see here, which helps facilities evaluate the quantities of supplies they have on hand versus the estimated quantities needed for a surge of patients. This is determined by demographic inputs that are entered on the first page of the module. And each module incorporates pediatric sizes and specific medication needs as appropriate to the incident. Another supply consideration that may be overlooked, I think, but has significant value when IV fluids may be in short supply, like we recently experienced, are oral resuscitation fluids, like Pedialyte. A 20 to 30% burn can be resuscitated with oral fluids. So an easily commercially prepared solution like Pedialyte or other water, sugar, and salt containing solutions should really be kept front of mind when planning for disaster incidents. They can really make a life-saving difference in your patients. Next slide. So in the United States, under normal conditions, we all know severe burns are immediately referred to the nearest burn center for care. But since a relatively small number of patients can quickly overwhelm any burn center, this type of referral paradigm may be detrimental during a disaster response. And realistically, patients injured in a burn mass casualty incident may not receive their burn care at the nearest burn center, but instead one within the region, which could be several miles away. Non-burn centers, such as trauma centers and general hospitals, may be called upon to stabilize these patients for up to 72 hours while awaiting sufficient resources to transport patients to more definitive care. A pediatric event makes it particularly difficult if pediatric capable transport resources are limited or unavailable, or when children are flown to a facility far from home, as that's an additional strain to the family dynamic. Next slide. So in 2005, Hurricanes Katrina and Rita separated over 5,000 children from their families, and most responding agencies had no pre-existing plans for family reunification. Consequently, following these historic events, it took over 6 months for the final child to be reunited with their family, which is just incredible. Children are extremely vulnerable. They're at high risk for significant physical and mental trauma, neglect, abuse, and even exploitation when they're separated from their adults during disasters. Next slide. So few hospitals have plans in general to care for children in disasters. And even fewer have specific plans to care for unaccompanied children and support their family reunification following a disaster. So establishing a family reunification site at both the impacted facility as well as all the surrounding facilities will hopefully mitigate the extreme delay in reunification that we saw on the previous slide. Hospitals, they serve as natural reunification sites. It's usually where family and friends go first, looking for those who are missing. FEMA is just one resource. They have a great document. They have a great resource document in the post-disaster reunification that you see here, as well as the Pediatric Pandemic Network at pedspandemicnetwork.org. They have many resources, including the Disaster Response Collaborative, where they do sessions. They provide sessions that cover a variety of topics. Actually, the next session is on January 7th, and it's on pediatric patient tracking and family reunification. So if anybody's interested in hearing more about that, please visit pedspandemicnetwork.org to sign up for that. Next slide. So for those of you who had looked at our region plan, we have a dedicated section for pediatric planning that was refined by our pediatric burn experts and our pediatric centers of excellence colleagues. And there is also an appendix for supplies that lists several supplies that may be needed during a pediatric response that can all be found in the plan and the appendices within the plan. Next slide. So just to summarize quickly, I know we just have about 1 minute left. Burn patients, obviously, they have a unique pathophysiologic response to their injury. This response requires injury-specific treatment. Early in a burn mass casualty incident, really the burn center's role is to support non-burn facilities with patient triage and transport decisions until they can be transferred when appropriate to burn centers for more definitive care. And so it's important for facilities to plan for the ongoing care of burn patients as well. We say typically up to 72 hours, but also know that you do have the support of your local and region burn centers. And so with that, next slide. If we have any questions real quickly.
Yeah, so and I do want to recognize it is the top of the hour, so if you have to get off, that's okay. This webinar will be recorded and posted on our website here. There was a question that came in that actually asked, what's your thoughts on water gel or burn gel for burns? I guess either one of you
Yeah,
could
Judy,
take
I
that
don't
one.
know if you have experience with it. I have no experience with it, but I just Googled it when I saw that question come in and looked at the ingredients and things. It looks like it provides a cooling pad that would be non-adherent, that would keep the wound clean. So another option as opposed to just a clean sheet or things like that, if you're transferring a patient for a temporary dressing early on. I do want to caution, just in my quick looking of it, I saw multiple versions of it. One that had triple antibiotic ointment impregnated on it. I would not recommend that. We don't usually recommend triple antibiotic ointment because of the high levels of dermatitis that we see from it. And I saw another one that was impregnated with lidocaine. And I'd be very careful using that, especially in a pediatric patient, especially with a larger burn, because it's going to be much more unpredictable about how much lidocaine the body's going to take up. And the last thing we would want to do would be get into a situation of lidocaine toxicity.
Okay.
Yeah, I agree.
Anything else with that, Judy, there?
No, that's fine. Just one caution too is these are things that we do see people come in with, as you can buy them over the counter. You can get them on Amazon, you can get them anywhere. And so just like Dr. Slater said, you do want to use caution, particularly ones with lidocaine and the antibiotic components.
Okay. One of the things I jotted a quick note down on here. I was wondering, as you were mentioning supplies and thinking about the dash tool and all sorts of things like that, I didn't know if you wanted to speak real briefly, because over the last 4-ish years, we've heard all sorts of things about the Strategic National Stockpile. And when you're thinking in terms of a mass burn casualty kit or casualty incident, I guess there's I think a misconception of what may actually be available in the Strategic National Stockpile for specific for burns, or if you wanted to speak to what can we get? What could a facility get from something like that? What would be available?
So I think it's important to recognize that the Strategic National Stockpile is not an immediate resource that's available to us. It's going to take a few days to get there. And so the SNS does have silver dressings in it. It does have our spray on skin. It does have debriding agents in it and things like that. But I think for the immediate care of these patients, we don't want to stray too far away from our principles of keeping them warm with dry sheets and blankets. If you're going to be caring for patients for longer than 24 hours, that's when you're going to start looking at needing to dress their wounds and addressing them and cleaning their wounds. And that's where the support of your burn centers can come in, and your telehealth support will come in. They will help you determine what type of burn you have, the degree of burn you have, and what's the appropriate topical that you might have available. The other thing with the DASH tool is they're going to have certain recommended dressings listed there, which it doesn't mean that if you have Adaptic and they put 0 form that's not going to be an appropriate dressing for your patient. It certainly is able to be interchanged. And so that again is something where you could lean on your burn SMEs, your burn centers, and for the first 24, 48, 72 hours before that SNS is available and before more resources are available. Number one, hopefully your patients have been moved to burn centers who need to be in burn centers. But also I would say we're going to need to be creative. Some of the things, like I said, like the saran wrap, even most places, buildings who have kitchens or schools or even your home, you have saran wrap. Those things are going to be very, very useful, like I said, in helping to hold dressings in place or prevent hypothermia.
You mentioned the idea of I guess the longevity of how long someone may be getting cared for and everything. And one of the questions that just came in kind of relates to that. It says, can any of the burn units, for example, in Lincoln, here in Nebraska, take children, or are they transferred to Children's Mercy in Kansas as soon as possible for care?
Yeah, no, I mean, they should be treated at the nearest pediatric burn center. So there are several of them in the region. Children's Mercy takes pediatric burns. University of Kansas is actually Kansas City's only ABA verified center for pediatric burns. But we take pediatric burns. Lincoln takes pediatric burns. So they should start going to the closest pediatric burn center. And if it is a disaster situation, then they're going to be in contact immediately with the region. And we're all going to be in contact to say how many can be transferred on to each of our different units using the tool that's kind of manned at that Children's Mercy. But that doesn't mean that they have to be transferred directly there. They should go to the nearest.
Right. And our coordinating center, they will be helping with that as well. Our burn coordinator, region burn coordinator will be helping with that as well. Like I said, if the pediatric facility or the burn facility is near the disaster or is impacted by any way, then we would want the patients obviously would need to go further away. But you want to always, again, typically single patient transfer, you go to the nearest burn center. Depending on the size and scale of the incident, patients perhaps are going to be moved to burn centers quite a ways away, which means they're going to be sitting in non-burn facilities for several hours up to days.
Okay. One last question here, and it's just asking for your thoughts on the cyano kits.
It just depends on the mechanism of injury. So we know that you're most at risk of a cyanide toxicity when you're in an enclosed space that has particles in the area that are burning that release cyanide, things like plastics and stuff like that, but not in an open situation. So if we're talking about an enclosed apartment fire, things like that, where there's significant smoke exposure, then certainly there's no rapid test for cyanide toxicity. And so we just give the cyano kit for those patients. If it's an open air area or there's no risk that you were burning anything with cyanide, then the patient doesn't need it. The nice thing about that is that most of the kits, once you have the kit, it's pretty much self like given. You don't have to put on a pump or anything like that. It just hangs by gravity. So it's not going to take up a lot of resources in a disaster situation.
Okay. That is all the questions that I see or anything like that. I appreciate everybody sticking on for the last bit of questions and answers here. Like I mentioned, the webinar will be recorded, posted to our website, and we'll make sure we get the emails out to everybody regarding continuing education. And definitely want to thank both of our hosts here for giving us all of this very in-depth information, and appreciate everybody stopping by, and have a great afternoon, everyone.
Thanks a lot, everyone.
Thank you.
Bye-bye.